Hello, I'm Hannah Donnert with the Collaborative on Health and the Environment. Change is bringing you the latest environmental health science through our partnership calls, webinars, science serves, publications, and social media. I would like to welcome everyone to today's CHE Partnership webinar, which is titled Cognitive Decline, Dementia and Parkinson's Disease, Environmental Contributors and Potential Pathways to Prevention. Our moderator today is Maria Valenti, Director of the Commonweal Health and Environment Literacy Project. We will leave time following the presentation for a brief Q&A session. You may type in questions through the Q&A feature available on the menu bar at the top of your window at any point during the presentation. After the presentation, our moderator will read out questions for our speakers to respond to. We will get to as many comments and questions as we can during the Q&A period. For those of you who called in on the phone, we have posted slides to accompany today's webinar on our website. You can download these by going to healthandenvironment.org. Please scroll to the bottom of the page and select today's webinar. On the webinar page is a link to the slides. Everyone on the webinar right now is muted with the exception of our moderator and our speakers. This webinar is scheduled to last for 60 minutes and is being recorded for our call and webinar archive. With that, I'll turn things over to you, Maria.
Thanks, Hannah, and welcome everyone. Today, our three speakers will address environmental risk factors across the life course for cognitive decline and dementia, including Parkinson's and Alzheimer's diseases. They will also discuss prevention strategies. Their presentations are based on scientific peer-reviewed information featured in the latest chapter of A Story of Health multimedia ebook and continuing education course. A Story of Health has been developed in a unique collaboration over the past 7 years among the Federal Agency for Toxic Substances and Disease Registry, the Office of Environmental Health Hazard Assessment at California EPA, the Western States Pediatric Environmental Health Specialty Unit, 2 nonprofits, Commonweal, and the Science and Environmental Health Network, and for some chapters, the Center for Integrative Research on Childhood Leukemia and the Environment at the University of California, Berkeley. Sam's story on cognitive decline and other chapters on asthma, developmental disabilities, childhood leukemia, and reproductive health and infertility are available to download free at the link on the webinar website. A Story of Health chapters are also offered as free continuing education courses hosted by the Centers for Disease Control and Prevention and ATSDR and can be accessed from a Story of Health website. Each chapter offers free continuing education credits to a range of health professionals and educators. To date, over 11,000 have registered for the free courses. Our first speaker, Dr. Ted Schettler, will address the ecologic framework of health and the many factors that influence individual and population health. He will introduce you to our main character in our story, 72-year-old Sam and his family, friends, and doctors, as they try to understand Sam's apparent cognitive decline that begins with after his wife dies and what might be done to address it. He will review the spectrum of cognitive decline, environmental drivers of chronic disease, and the protective role in nutrition and exercise. Dr. Schettler is the science director of the Science and Environmental Health Network, a longtime partner in this project. You can read more about him on the website. Our second speaker is Dr. Mark Miller. He will address early life exposures to toxicants such as lead and air pollution, the psychosocial and socioeconomic factors that may influence dementia, and provide an overview of public policies that may have had an influence on the rates of dementia. Dr. Miller is an associate clinical professor of occupational and environmental medicine at the University of California, San Francisco, co-director of the Western States Pediatric Environmental Health Specialty Unit, and the director of the Children's Environmental Health Center at Cal EPA. Again, you can find more about Dr. Miller on the website. Our last speaker is Dr. Samuel Goldman. He is professor of clinical medicine at the University of California, San Francisco, in the Division of Occupational and Environmental Medicine and the Department of Neurology. He is also a staff physician at the San Francisco Veterans Administration Medical Center. He will cover a range of topics related to dementia, Parkinson's, and Alzheimer's diseases, including environmental risk factors such as pesticides and solvents. He'll cover gene-environment interactions and traumatic brain injuries. He will briefly cover how to evaluate for cognitive decline and provide a short summation of prevention strategies. In the interest of time, speakers will not be able to cover many of the topics we examine in Sam's story in the ebook, which is about 50 pages plus long. So we encourage you to download it for free. It's It's listed on the webinar website. And just as a reminder, we'll have a question and answer session at the end, so please do send in your questions so we can get to them all. And with that, I'll turn this over to Dr. Schettler. Ted?
Thank you very much, Maria, and let me also extend my welcome to all of you who have joined us today. As Maria mentioned, in Story of Health, we use an ecologic model of health to frame and provide some context to the stories and the data that we review in not only this chapter, but all the other chapters in this project. An ecologic framework explicitly acknowledges the convergence and interaction of numerous variables that influence both individual and population health, many of which are shown here on the right side of this slide in this diagram over here. You can see, for example, occupation, social support, education, chemical exposures, the natural and built environment, economics, various other stressors, access to healthcare and nutrition. These are just examples of the many variables that can influence or do influence individual and population health. The ecologic framework recognizes that individuals are progressively nested within families, communities, ecosystems, and societies with variables that influence both individual and population health. And this is more than a theoretical framework. We think, for example, of air pollution or neighborhood safety or the cost and availability of nutritious food as being examples of neighborhood or community level variables that strongly influence individual health. Interactions are a primary feature of this framework. Each level can be reflected in individual biology down to the cellular and even subcellular levels. As you see here on this diagram, time is also an important consideration in this model. We will hear, for example, of the importance of timing of exposures during vulnerable life stages and how they can have disproportionate impacts. There's also the whole issue of lifetime exposures and then changes in exposures over both historic and evolutionary time that influence population health and disease and health patterns. So to our story, who is Sam? He, as Maria mentioned, is a 72-year-old widower from the baby boom generation who grew up and still lives in the Boston area. His wife of over 40 years passed away last year. Since her death, he's not been as socially active and doesn't see friends and family as much as he used to. And his family is concerned that he's forgetting things more often than usual and missing appointments. And they wonder if this is normal for someone of his age or if there's something else going on with his brain function. So that sort of sets the stage. And what you'll see here on this slide are just examples of some of the features in this story where if you click on these little icons here, for example, you will see pop-ups come up that, for example, describe aging in various countries around the world. So one of the topics that comes up that I wanted to just briefly touch on here is this whole issue of whether Sam's cognitive decline is a normal feature of aging or whether something more serious is going on. And you'll see here, for example, on this slide, an opportunity to click on this icon and you will get a brief summary of forgetfulness as it tends to arise as people age and whether it's normal or not. And then in this other box just below it, you can get a pop-up here on dementia and mild cognitive impairment, which is all of this text over here on the right side. The important take-home points are that mild cognitive impairment, which is characterized by trouble remembering names or appointments, more often than just occasionally, trouble finding the right word, misplacing things, not necessarily progressive. Over time, it will become clear if it is progressive and may lead to dementia. But when it first arises, it is somewhat more severe than the normal forgetfulness of aging, but it's not apparent whether or not it's going to progress or not. On the other hand, dementia, which is persistent and progressive, disruption of mental processes marked by memory disorders, personality changes, and impaired reasoning. And regardless of what the diagnosis is at the outset, it's important to look for correctable causes, things like depression, medication side effects, thyroid problems, vitamin deficiencies, and excessive alcohol use are just examples. And we do review that in a little bit more detail in the story of health. Now, what you'll see here in the bottom here is an example of a video that we embed in this story. And if you click on this icon here, you can actually watch this video in real time. It's an animated video with a voiceover that ends up looking something like this, where it shows the various environmental factors that I've described previously, how they can, through impacts on cells and tissues, through biologic mechanisms that are well described and increasingly well understood, result in chronic diseases or disorders. And you'll recognize many of these as being very common: diabetes, obesity, abnormal serum lipids, metabolic syndrome, cardiovascular disease, and how these same biologic mechanisms can also increase the risk of cognitive decline and dementia, including Alzheimer's disease. What we have noted is that people with midlife obesity, diabetes, and abnormal serum lipids are actually at increased risk of cognitive decline and dementia later in life. So this begins to introduce the importance of taking a life course approach to prevention of these later life diseases and disorders. We do cover in Sam's story a number of lifestyle factors that we can think of as either risk factors or protective factors, depending on how we approach them. I've listed a number of them here on the left-hand side of this slide. These are protective lifestyle factors in order to preserve cognitive function, things like avoiding smoking, treating hypertension, preventing or treating hearing loss, a surprisingly important contributor to the risk of cognitive decline later in life. Improved or emphasis on social engagement is important. Avoiding excessive alcohol use, regular exercise, and healthy nutrition. All of these are individual level variables that can influence the risk of cognitive decline later in life. And I just want to briefly comment a little bit more on the importance of physical activity because the data are increasingly strong in that regard. Regular exercise is really an important component of a multifactorial approach to maintaining cognitive health and slowing decline. It may also help prevent or slow progression of Parkinson's disease. And of course, as we know, it also helps prevent or slow progression of a number of other chronic diseases or disorders. So this is an important thing that people should be encouraged to incorporate into their daily activities as much as possible. I also briefly will mention the importance of nutrition. It's increasingly clear that from observational studies that nutrition can play a role in preventing or slowing cognitive decline, and in particular, the Mediterranean diet has showed promise in that regard. The Mediterranean diet features lots of fruits and vegetables, whole grains rather than refined carbohydrates, healthy fats, and by healthy fats, I mean not only an emphasis on polyunsaturated fatty acids, but also making certain that among them you're getting enough omega-3s, which are often lacking in a fairly typical Western diet. And then the Mediterranean diet also features olive oil as a source of monounsaturated fats. The Mediterranean diet includes fish and poultry, beans and other legumes, and only moderate dairy and very limited red meat and limited red wine. So that's an example of a diet that, when followed, can actually help prevent or slow not only cognitive decline, but also some of these other chronic diseases of aging in our country. So just finally, we weave all of these and other variables that you'll hear about together in Sam's story, starting years before his clinical presentation. We follow him through his initial clinical evaluations. And now I want to pass this off to Mark and then to Sam for more detail about various risk and protective factors across the lifespan. So Mark, I pass it off to you.
Okay, thank you. Just having trouble finding. I'm sorry, I'm having trouble.
Okay, Mark. If you want to just, if I can, happy to share your slides, or if you want to go down to share.
I'm sharing, but it's you know, that screen came up that
would you like me to share your slides?
Why don't you share the slides for me?
Okay, I'm happy to. Here, one sec, I'll pull it up for you. Here we are.
Excellent, thank you.
You're welcome.
First of all, though I work for California EPA, I'm not representing the state of California today in my comments. Next slide. So a key element of the story of health, as Ted has been discussing, is the ecologic approach. And a key to that is paying attention to the importance of social interaction on cognitive health. Here in this part of the story, Sam admits that he has been more isolated since his wife's death and generally not functioning at the level that he had previously been. Next slide. So you can click on the importance of social interaction in health that was on that last slide, and it comes to information derived from the National Institute on Aging very nicely. It's well documented that social relationships are consistently associated with biomarkers of health. So one of those being interleukin-6, and that when you see positive indicators of social well-being, you have lower levels of interleukin-6, which is an inflammatory marker and is associated with Alzheimer's disease, cardiovascular disease, a great many other disorders. Social isolation constitutes a major risk factor for morbidity and mortality, just in general for older adults, and loneliness is a risk factor for depression. So loneliness and depression have a synergistic adverse effect on well-being in middle-aged and older adults, and including on cognitive function. Next slide. So also on that page is a link, as we try throughout the story, to link to these outside resources that give much more information and practical information. So in this one, a community resources document called Livable Communities, and an evaluation guide from AARP. And you can see from the table of contents, it tells you how to do a community survey that is important for livable community, and particularly for livable communities for aging population. So transportation, walkability, housing, a caring community. How do you design a community or improve your community to make for a healthier community for an aging population, which includes a number of factors that are indeed related to cognitive decline. Next slide. In this part of the story, Sam is speaking with his physician, Dr. Gomez, and he admits to being depressed. So you see several things you might click on alcohol and dementia risk. Alcohol consumption is indeed associated with higher risk for cognitive decline. And even there's some evidence that in utero exposure may impact later life cognitive impairment. There's a place to look at more information on psychosocial and socioeconomic stressors. And the concept introduces the concept of allostatic load, which is really the kind of combined impact of all levels of stressors on an individual. So if we click on psychosocial and socioeconomic stressors, next slide, we find information that includes information that early life and earlier onset depression increases the risk of cognitive impairment and dementia, that major depression may increase the risk for dementia, but also importantly, may be a reaction to cognitive decline, so that major depression may or may not be a causative factor in the dementia, but may be a result of your cognitive decline. Chronic and perceived stress is associated with faster decline, not only in those with mild cognitive impairment, but also in healthy individuals, and that lower socioeconomic status is associated with an increased risk for memory decline and dementia. Next slide. In this part, we take on some of the underlying workplace-related risk factors, and these include exposure to lead and neurotoxicant solvents. Click. So, next slide. Yeah, thank you. On the page, there's a embedded, probably about 3-minute video that Sam did on lead and neurodegeneration. Next. And you know, sticking with this concept that aging begins at conception, that this is a life course thing, that early life exposure may indeed relate to risk for later life disease, as Ted mentioned earlier. Next. So with lead, there's a very interesting study that was done almost by happenstance. There was a monkey colony in Canada that Deborah Rice, a neurotoxicologist, was running, and they wanted to look at lead exposure early in life. And they gave monkeys lead that gave them blood lead levels about 19 to 25 micrograms per deciliter, certainly similar to relatively common levels of exposure in children in the 1970s in the United States, but still similar to some children today. And then after they had studied that, they let the colony live. And somebody thought at 23 years of age now that these are aged monkeys, to look at them again, and particularly for risk factors related to cognitive decline and dementia. So they saw increased expression of Alzheimer's disease related genes, including amyloid precursor protein, and altered levels and distribution of plaques in the frontal cortex, and epigenetic changes that supported this as a mechanism of early life lead exposure, resulting in Alzheimer's disease-related pathology later in life. Next slide. Specifically on air pollution, we look at a number of things, and Sam will talk more about air pollution later in life and risks. But I just wanted to, being a pediatrician and my interest being in the early life exposures, bring up that autopsy studies comparing the brains of relatively young people, adolescents, who died accidentally in Mexico, and compared highly polluted cities with those with much cleaner air, found a great number of inflammatory markers, accumulation of amyloid beta, and inflammatory activation of endothelial cells lining the blood vessels, and pathology that really looked like in those associated with the high air pollution areas, pathology those of much people. And this was accentuated in those with genotypes that were particular risk factors. Next slide. So lastly, I'd like to emphasize that we do tackle both individual activities that may improve health and prevent long-term disease, but also about community, business, and public policies on all levels. Next. One example of that is the steady decline in blood lead levels that are a result of a great number of different activities. Mean toddler blood lead levels have gone from around 16 or so in the 1970s to less than 1 microgram per deciliter today. There's a similar decline from around the same high levels to around 3 or so today in adults. Next slide. Similarly, this just is a California example, but when we put our minds to it, there's a lot we can do. California, air pollution from gasoline use certainly was a source of lead prior to 1978. And now it isn't, but there's a great number of volatile organic compounds and other particulate matter, et cetera, that is in fact related to cognitive decline. So these are regulatory and gas reformulation activities that over a period of 25 years dramatically decreased the emissions from gasoline use. The top green line is gasoline use itself. So it dramatically reduced it without even affecting for the same amount of gasoline use in the state. The emissions were dramatically reduced. Thank you. Now I'll turn the slides over to Sam.
Great. We're waiting for Sam to come up. There he is. Please feel free to put in your questions in the Q&A box down at the bottom of the features.
Good morning, everyone. I hope you can hear me and see my slides okay. I'm going to be focusing on some of the environmental risk factors for neurodegenerative diseases, primarily Parkinson's disease and Alzheimer's disease, as these are the focus of Sam's story. I don't have time today to talk about the clinical or pathological aspects of these diseases, but there's some excellent references listed at the end of the story. When investigating the causes of disease, the first thing we need to determine is whether it's primarily caused by genes or by environment. And to study this in Parkinson's disease, we conducted a very large study in 32,000 elderly twins. And the way the premise of this is that identical twins or monozygotic twins share 100% of their genes, and fraternal twins or dizygotic twins share approximately 50% of their genes. So if Parkinson's is primarily a genetic disorder, we would expect concordance, or both twins have the disease, to be much higher in identical twins than in fraternal twins. And what we observed is that there was very similar concordance in identical and fraternal twins. We found that if disease onset was very young, under age 50, that there was very high heritability or strong genetic component. But at the more typical ages of Parkinson's onset, over age 50, there was a very low genetic component. So we concluded that environment is a major contributor to the cause of typical Parkinson's. And what we noticed, very interesting, was that there was high concordance in the fraternal twins, about 3 times higher than in other first-degree relatives. And this suggests that the effect was due to a shared early environment. Pesticides have been associated with an increased risk of Parkinson's in more than 50 studies around the world, and Sam's story goes into some detail on this. In this chart, each blue block is the estimated risk of Parkinson's associated with pesticide exposure in a particular study. So any block to the right of the solid line found increased risk of Parkinson's, whereas blocks to the left of the line found a decreased risk associated with pesticide exposure. And you can see that virtually all of the studies found an increased risk, and the summary increased risk down at the bottom here shows about a 60% increase in exposed individuals. However, specific agents have rarely been studied, and that's in part because most people don't know what agents they were exposed to. So to address this, we studied Parkinson's in the agricultural health study. This is a cohort of about 80,000 professional pesticide applicators and their spouses. We asked about the use of 31 specific pesticides, and these are excellent historians because they're professional applicators. They have to keep detailed records of what they used. And we found that only 2 pesticides were significantly associated with Parkinson's. These were rotenone and paraquat, both of which caused 2 to 3-fold increased risk of Parkinson's disease. Now, rotenone is an insecticide that used to be used in many consumer products, including pet flea powders and many sort of home and garden products. Currently, its main use is to kill invasive fish species in rivers, lakes, and reservoirs. Paraquat is one of the most commonly used herbicides in the US, although it's been banned in Europe, China, and in many other countries. Now, what's really important about this observation is that both of these pesticides damage mitochondria, which are thought to be very important in Parkinson's disease etiology. They both generate oxidative stress, and they both cause a Parkinson's model in rodents that share many of the features of Parkinson's disease. Pesticides have also been linked to an increased risk of dementia, though the data aren't quite as strong as for Parkinson's. And Sam's story goes into more detail about this. As you can see from this chart, most studies found an increased risk. They're to the right of that solid line in the center, with a summary increase of about 34%. But similar to Parkinson's, very rarely have specific agents been linked. One example in particular, a study by Richardson et al. About 5 years ago, they looked at DDT and its primary metabolite, DDE, in serum. And DDE is highly persistent with a half-life of around 10 years. And in this figure, you can see the individual levels of DDE in serum from control subjects and participants with Alzheimer's disease. You can see that the mean level of DDE in serum is considerably higher in patients with Alzheimer's. And those in the highest third of DDE levels actually had a 4-fold increase in Alzheimer's risk. Exposure age might be particularly important. And this was studied in a large study in Salinas Valley, California, where lots of pesticides are used. And they mapped pesticide application data to the mother's residence during pregnancy. And similar to what Mark discussed with regard to early lead exposure, turned out that maternal exposure to pesticide was associated with lower IQs in their children. And experiments in animal models find similar results. You can see here there are small but significant decreases in IQ associated with exposure of the mother to a variety of organophosphate and other pesticides. And there are many studies in humans showing that lower IQ is associated with an increased risk of Alzheimer's disease. So it's reasonable to extend this to expect an increased risk of Alzheimer's in children whose mothers were exposed to certain pesticides. In this page from Sam's story, Sam's doctor explains to him that the risk for diseases like Alzheimer's depends on both genes and environment, or so-called gene-environment interaction. This slide shows an example of gene-environment interaction from our work. The environmental risk factor here is use of the herbicide paraquat. The genetic risk factor is a metabolic gene called glutathione S transferase T1, long name, but GST-T1 is what we call it. And in this graph, we've got 4 groups. So we stratify on whether or not GST-T1 is present and whether or not they were exposed to paraquat. The reference group is people who have functional GST-T1 but no paraquat exposure. The next bar shows a very slight increased risk in people who are lacking GST-T1 but had no paraquat exposure. The next one shows individuals who have functional GST-T1 who were exposed to paraquat, and there's about a 50% increased risk. The final bar shows individuals in whom GST-T1 was absent and who were exposed to paraquat. So the green is the effect of the gene, the yellow is the effect of the exposure, and the red is the interaction between the gene and the environment. So there's an 11-fold increased risk in people who had both the genetic risk factor and the exposure. What's particularly noteworthy here is that this is not a rare variant. Approximately 20% of the population is lacking functional GST-T1. I'm going to switch over to solvents here. So solvents are chemicals that are good at dissolving other substances, and solvent exposures occur in a huge varieties of industries and occupations. We know that acute solvent intoxications can cause cognitive impairment and Parkinsonism, which are the symptoms of Parkinson's disease. And these include methanol, hexane, and various other hydrocarbon and solvent mixtures. But associations of solvents with Parkinson's disease are not consistent. In 2008, Gash et al. Discovered a cluster of Parkinson's in a small industrial plant that did metal degreasing and used a lot of trichloroethylene. And other workers in this same plant were exhibiting some mild Parkinsonian signs and symptoms. TCE is a very commonly used solvent since the 1920s. Its primary use today is degreasing metal parts and computer circuits. It was used in dry cleaning since the 1950s as a surgical anesthetic. It was used to decaffeinate coffee and was in a variety of consumer products, including typewriter correction fluids, paints, and carpet cleaners. And importantly, TCE is the most frequently reported organic contaminant in groundwater. Some of you may be familiar with the contamination at Camp Lejeune in North Carolina, and that the major contaminant there is TCE. So we investigated the association of solvents and Parkinson's disease in the twin study that I described earlier. And of all the solvents that we studied, we found 2 that were associated with Parkinson's risk, and these are occupational exposures. We found a 6-fold increased risk in twins exposed to TCE and a 10-fold in twins exposed to PERC, which is a very similar compound. And in a rat model, oral TCE exposure causes a selective degeneration of dopaminergic neurons in the substantia nigra. And these are the neurons that specifically degenerate in Parkinson's disease. And on the left here, you can see the normal, the control dopaminergic neurons. And on the right, you can see the dopaminergic neurons after exposure to TCE. So let's shift gears here a bit and talk about air pollution and dementia. This is a study from a couple of years ago that looked at the risk of dementia associated with proximity to major roadways in Canada. The values in the red box show a significantly increased risk of dementia in persons who lived within 50 meters of major roads. And you can see this kind of dose response where risk gradually decreases as the distance from major roadways increases. So seeing this dose response is very compelling. Mark alluded to this. There's a study in Mexico City, which is an area of high air pollution. And this study looked at brain pathology in healthy adults and children who died acutely from traumatic causes. And they found increases in the protein that forms the amyloid plaque seen in Alzheimer's disease. And so this is A beta 42, and you can see that's in brown here. And in blue, these are blood vessels. And what's really interesting is that the amyloid protein seems to be accumulating in the proximity of blood vessels. And this suggests that whatever is causing the increases in amyloid is entering through blood vessels. And this was not seen in individuals from less polluted cities in Mexico. So what might be causing this pathology? This is a really interesting recent study that suggests that one of the pollution-related factors associated with pathology in the brain may be tiny particles of iron oxide. And these so-called nanoparticles are only 10 to 30 nanometers in diameter. These are really tiny, so that they're able to pass directly through the sinuses into the brain. And these particles were found at autopsy in normal individuals, and they were within the frontal cortex in the proximity of the olfactory bulb, which projects from the sinuses. These particles are thought to be derived from automobiles, but the particles are 100 times smaller than the smallest particles measured by the federal and state agencies. We don't even know how to measure them reliably. Another risk factor for neurodegenerative disease that's discussed in some detail in Sam's story is traumatic brain injury. And this slide is a chart that shows approximately 18 studies of head injury and Parkinson's, each line being a separate study. And each of the black dots is the risk of Parkinson's associated with head injury for a particular study. This dotted line is sort of the null or no effect. So dots to the right are increased risk, dots to the left are studies that found a decreased risk. And you can see that the human epidemiology is fairly consistent, finding increased risk associated with head injury. And this has been replicated in a mouse model of traumatic brain injury, where they use a percussion to the skull, and they find that there is increase in, this is staining for alpha-synuclein protein on the right, and that's the protein that accumulates in Parkinson's disease. Some of you may be familiar with chronic traumatic encephalopathy, or CTE. I'll just mention it briefly here. So this previously was called punch-drunk syndrome or dementia pugilistica back in the 20s and 30s. The term CTE was coined in 1949 by Critchley. And then it was largely forgotten and ignored. And there was renewed interest after a report of CTE in an NFL player in the, I think it was 2005. And though the pathology is different, CTE can have clinical and pathological features similar to Alzheimer's, Parkinson's, and other neurodegenerative disorders. And this is a progressive neurodegeneration, so even after the injuries stop, the disease progresses, and it's associated with repetitive head trauma and cognitive and behavioral syndrome. As described in Sam's story, in order to fully understand a patient's illness, it's essential to know about their lifetime occupational and environmental history. So I want to touch on this briefly. So this is a quote from Ramazzini. He was an Italian physician from the 1600s who's considered the father of occupational medicine. I'll just read this quote. "When a doctor arrives to attend some patients of the working class, let him condescend to sit down, if not on a gilded chair, on a three-legged stool. He should question the patient carefully. So says Hippocrates in his work, Affections. I may venture to add one more question. What occupation does he follow? And 400 years later, taking an occupational history is still rarely done. This is a study from 2004 showing the frequency of various patient histories taken by primary care physicians. They did a record survey, a review, and they found that only 28% of records contained any information on the occupational history. So a thorough occupational history only takes around 10 to 15 minutes to perform. It should focus on the entire lifetime, all occupations and industries. It should ask about specific job tasks and processes, or any products produced in that occupation, what compounds and materials were used, and patients may not know what compounds or materials were used, so that's why it's important to ask about tasks and processes. Did they use any protective equipment, such as gloves or masks? Were they ever ill at work, and were others who worked with them ever ill? And it should include a military history, so asbestos and lead and solvent exposures are very common in the military, and pesticide exposures such as Agent Orange. It should also include a brief hobby history and questions about household exposures, including pesticides and other agents. So we've talked a lot about risk factors for neurodegenerative diseases, and there's a lot more detail throughout Sam's story. But what's hopeful about Parkinson's and Alzheimer's is that both of these conditions likely begin in middle age or even earlier, and they take decades to progress to overt symptoms. So we can find early Parkinson's pathology, such as aggregates of alpha-synuclein protein in the intestines, possibly 30 or even 40 years before Parkinson's presents. And similarly, with Alzheimer's disease, we can actually see neurofibrillary tangles in a proportion of people under the age of 30. So that's terrifying, but it's also hopeful because it means that we may be able to intervene in the pathological processes by changing our lifestyles, increasing physical activity, improving our diets, and by reducing exposure to environmental toxicants. And on that note, I'd like to yield to Maria for any questions that you might have.
Thank you so much, Sam. We have gotten a number of comments that are congratulating all three presenters for your wonderful presentations. And in fact, you all have an invitation to attend the CEH Inches conference in Amsterdam as presenters. So you can take that offline with Mr. Guy, who has made that offer. But we do have a number of other questions here, and I'll start with one on question on treating hearing loss. And this question says, how or why does treating hearing loss prevent onset or progression of dementia? And can seemingly lost function be restored or reversed? And Ted said that he'd be willing to answer that question. So Ted?
Yeah, thanks for that question. It's an observation that people with progressive hearing loss are at greater risk of cognitive decline. And the theories that have been promoted to explain that are twofold, as I understand them. One is that as people become progressively hard of hearing, they actually become more socially isolated. And I think that's an observation that many of us have made of people who do have difficulty with hearing, that they're simply cut out of many conversations and many social interactions. The other theory that's been promoted is that it requires increased concentration and cognitive effort to interpret what's being said, or what what sounds are in the environment that then detracts from applying those cognitive skills to, in other ways. So the recommendations from people who have studied this field are to make certain that hearing loss is identified and treated, with the hope that doing that will reduce its influence on progressive cognitive decline.
Thanks, Ted. Our next question is from a dietitian from Ecuador. And she has said that she's seen many dentists advertising the removal of toxic mercury fillings to avoid disease and dementia, and that many seniors there are opting for this treatment. She says she's did some research noting that the American Dental Association does not recommend this, but some countries have banned the mercury amalgam. And what are your thoughts about this treatment? And Ted said that he would be willing to answer that question as well.
Well, there are two parts to that. One is that I think dentists in the United States and elsewhere are increasingly getting away from using mercury amalgam fillings in the first place because of the recognized neurotoxicity of mercury and the increasing availability of safer and effective other composite fillings. But to the issue of removing mercury fillings that were placed, I don't know of any data that suggests doing that has a benefit to cognitive function. Maybe I missed it, but I don't know of any. But what I do know is that that older mercury amalgam fillings are releasing less and less mercury into the patient's mouth as the years go by. But when you remove mercury fillings with the intention of replacing them with something else, you actually create a pulse of mercury exposure, which then could be internalized by a patient, either by inhalation or by ingestion. So they actually will get at least a temporary spike in mercury exposure. So my understanding is that many dentists, at least in the United States, are not recommending wholesale removal of mercury fillings if they've been in place for years for that very reason.
Okay, thanks, Ted. We have a number of comments and questions, but I'll go back to an earlier question that came in from a person who says, we have considered advocating at municipal cost the monitoring of particulates and noise and other vibrations as data gathering necessary for thinking about health harms that affect our city. Any thoughts on the importance and or feasibility of electromechanical detection of environmental harms? Any one of our panelists like to take a thought about that?
Well, this is Sam. I'm not entirely sure what they mean about electromechanical, but monitoring of particulates and criterion pollutants such as nitric oxides and lead is done routinely by dispersed monitoring stations. Sometimes the density of these monitoring stations isn't really sufficient to get the detail that we need for a very focal determination of risk. So I think that's really important to monitor for these agents. As I mentioned, the most harmful agents might be these nanoparticles, very tiny particulates that currently we don't have good methodology to assess.
This is Maria. I'd like to just jump in and say that I know in my own community there are actual local ordinances on noise that and state ordinances on noise that describe certain levels as public health hazards. So I would look to the local ordinances to see if those already exist. Okay, so moving on to another question here, going back to hearing. Is there evidence for effects on hearing from exposure to toxic substances such as solvents? Sam?
Yeah, actually there is a literature on that. And what's particularly interesting is that risk from many ototoxic agents is actually magnified by exposure to alcohol. So one might imagine situations where, well, alcohol being, of course, a solvent, but solvents also increase sensitivity to noise, so that people exposed to solvents may actually have more damage to their hearing when exposed to noise levels that otherwise might not be damaging.
Okay, there's quite a number of questions that have come in, and I'm not sure we're going to get to all of them in the time that we have left, but we will respond afterward to the questions. Here is a question that starts off with Antoine Hakim, founder of the Canadian Stroke Network, and wrote a book called Save Your Mind. And although he does recognize other factors, the overriding most common cause of dementia in adults, according to him, is cardiovascular risk factors. Thoughts?
Well, this is Sam again. Cardiovascular risk factors are certainly important. The most common cause of dementia is Alzheimer's disease. There are vascular forms of dementia that are also very common, caused by, well, the same factors that would cause atherosclerotic heart disease cause atherosclerotic brain disease. So controlling hypertension and cholesterol are going to be effective in that. But there are also very strong associations of vascular, atherosclerotic factors and Alzheimer's disease. So the strongest risk factor for Alzheimer's disease is a genetic factor called ApoE, apolipoprotein E, which is a cholesterol-carrying molecule in the blood, and individuals who have a particular subtype of ApoE are at markedly increased risk for Alzheimer's disease.
Okay, here's one on lead. Would exposure to lead in water due to lead-based water pipes exacerbate or increase risk for Alzheimer's? Oh, wait a second. Already present due to early life exposures effect. I'm not sure I understand the question, but.
Well, Maria, I'll comment on that briefly.
Okay.
I think that the take-home message is that lifetime exposures to lead are additive. So you begin with childhood exposures, and then, adolescent, midlife, and later life exposures. The studies that have been based on observational studies that have been based on that have been studying associations between lifetime lead exposure as estimated by bone lead levels and cognitive decline clearly show a relationship, show an association. So, lead is bad anytime. Lead exposure is bad anytime along the life course, and more is worse. So I think that's why the material that Mark presented is so important, because we've done a lot to get children's blood lead levels down, but we've also have 45 years of lower adult lead exposures as a result of those public policy interventions. So I think we want to think across the life course.
Thanks, Ted. we've had a number of questions about sharing the slides and the resources. Those slides and resources are available online on the webinar website. This has also been recorded, and you will be able to listen to the recording afterward. And I believe the emails of the presenters are also available if you wish to. There are several people that wanted to contact the presenters privately, and if the presenters are comfortable with that, we can post their emails on the website as well. I think we're at the top of the hour. Hannah?
Yes.
Is that?
Yes, yeah. Let me just close this out for you, Maria.
Yeah, let me just apologize for not being able to get through to all the questions. There were also a number of comments, but like I said, we will attempt to answer the questions. If you've given your name and email, we can get back to you.
Great. Thank you so much, Maria. We're approaching the end of our webinar today. A video recording will be available on CHE's website soon, and tomorrow you will receive an email containing a link to the video. The next CHE EDC partnership call will take place January 15th, which is tomorrow, and is titled Maternal and Neonatal Effects of In Utero Exposure to Perfluoroalkyl Ether Acids in the Sprague-Dawley Rat. To learn more and to RSVP, please visit our website at healthandenvironment.org. If you are new to CHE and would like to stay updated about upcoming events or more, please sign up to receive our newsletter by selecting the Join Us tab at the top of any page on our website at healthandenvironment.org. Additionally, if you appreciate these CHE partnership webinars bringing you the latest environmental health research for free, we encourage you to support CHE's ongoing work by making a tax-deductible donation via our secure website. Again, our website is healthandenvironment.org. With that, I would like to thank our speakers, Dr. Schettler, Dr. Goldman, and Dr. Miller for taking time to present today. And to you, Maria, for your excellent moderation. Thank you so much for joining us, and have a great day.